All right, welcome back, everyone. Let's take a look at the atrial rhythms now. So we just finished the sinus rhythms. Let's take a look at the atrial rhythms now. So the atrial rhythms are rhythms that originate somewhere in the atrial tissue, but not inside the SA node. So they can kind of come from anywhere in here. They can come from the left atrium as well, kind of back here. Actually, they showed here, sorry. But it cannot come from here. So under no circumstance can the rhythm come from here. So if the rhythm is not originating in the SA node, we can't call it a sinus rhythm. And certain things are going to happen. For example, one of the characteristics of sinus rhythms was the presence of a P wave, for example. Well, in atrial rhythms, you're not going to have a P wave because P waves only come from the sinoatrial node. And if the originating impulse comes from somewhere outside of that SA node area, then it's going to look different, and that difference is going to be no P waves. So we're going to take a look. Remember, this is still occurring in atrial tissue. That's kind of an important thing to remember there. So we're going to take a look at the important couple of atrial rhythms. Atrial rhythms include atrial fibrillation. Atrial fibrillation, when it's in normal rate, is called AFib. When the atrial fibrillation rate exceeds 100, it's called atrial fibrillation with rapid ventricular response. So we'll look at both of those. We'll look at atrial flutter. This is one of the most commonly misdiagnosed rhythms out there today. It's difficult to interpret sometimes, but we're going to show you some tricks to alleviate that. SVT is called supraventricular tachycardia, so it's coming from above the ventricles, but it's fast, so it's SVT. And then the last thing is we'll talk about premature atrial complexes. Premature atrial complexes. These are actually not rhythms. They're occurrences that happen within a rhythm. They're not rhythms in and of themselves. We'll talk about those. So we're going to add like 4 or 5 new rhythms to your toolbox here. All right, so again, the rate here, we're going to measure the rate here in just a second. I just want you to take a quick look here. What jumps out at you? Something should jump out at you about this rhythm right away. And hopefully what you said is the regularity. So right away we can look that this is not regular. Now, is there any pairing to this, or is there any grouping? Well, right away it kind of looks like these guys are grouped, but then if you actually measure the distance between these things, they're not. So this is an irregular rhythm. So this is the second of 5 irregularly irregular rhythms that we'll look at. Irregularly irregular rhythms make things so much easier because it rules out like 25 to 30 other possibilities right off the bat. All right, so the next thing we're going to look for is what the rate is. All right, so you can use, I believe this looks like a 6-second strip-ish. Let's see here, 1, 2, 3, 4, 5, 6, 7, 8, 9. Let's call it 10. So the rate here, I'm going to make this rate about 90, because I need the number to be a little less than 100. So I think it's right around the 90 mark anyway. Remember, when you have an irregularly irregular rhythm, it's kind of hard to figure out what the rate is. So we're going to average this, and we're going to come up with a rate of about 90. Now, I challenge you to find some P waves next. That's what we always look for. So you're going to go to any QRS complex that you want, and you're going to kind of look in this area for a P wave. And do we see what appears to be a nice rounded P wave? Well, no. All right, well, let's look somewhere else. How about here? Well, that kind of fits the mold. How about here? Nothing. How about here? Nothing. How about here? Well, maybe. How about here? Well, maybe. So all these things here, we're going to look at this, and we're not going to really find any nice-looking P waves. So actually, there are no P waves here. There are no P waves here. But if you look at the underlying rhythm here, you take a look at the isoelectric line here, I think what you'll notice is something very obvious that jumps out at you, and that's called a fibrillatory baseline. So if you look at this, you get all these little fibrillatory waves. This is kind of like what ventricular fibrillation looks like, only it's even finer. You get all these little fibrillatory waves here with absolutely no discernible wave in there. So I'm going to label them as F waves with a little f. All right, fibrillatory waves are F waves. They're also very indicative of this rhythm. All right, if there's no P wave, can you measure a PR duration? The answer is no. And then let's look at our QRS duration here. How about we start it there, we end it there. We're at like 2 boxes. Let's call it 80 milliseconds. All right, so atrial fibrillation, this is atrial fibrillation, is characterized by a rate less than 100, an irregularly irregular rhythm, no P's, no PR duration, and usually normal QRS duration. Right? Normally. It can be different than that. We'll get there one day. So these are the characteristic findings. When you see this grouping of 5, this constellation of 5 findings, this is diagnostic for atrial fibrillation. All right, let's look at the next one. All right, so same thing here. Let's look at this. I think this is this might be a 10-second strip. All right, let's take a count. So if this is a 10-second strip, we're going to end up having to multiply it by 6. So we're going to count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. So 20 times 6 gives us 120. All right, so that's our rate, 120. Now, let's look at regularity. Now, be careful here, because it's easy to overlook this and to call this something like sinus tachycardia, even though it's nowhere near sinus tachycardia. If you don't apply these rules and you don't carefully look for these things, you're going to miss stuff and you're going to improperly diagnose or interpret the rhythm. All right, so let's take a look at irregularity. It kind of looks like they're pretty close, but then there's some of these guys that are really obvious. Like, look at this guy and then look at this guy. These are nowhere near one another. These are all irregular. So this is an irregularly irregular rhythm. Irregularly irregular. Now, when you look here, you're going to go back and you're going to say, hey, I'm going to look for P waves. So you're going to go back to the area where you think there's a P wave, and sometimes you're going to show up and this is going to happen to you. Or this guy is going to happen to you, or this guy, and you're going to say, well, you know what? I don't really know what that is. It might be a P wave that's a little bit tall, but certainly it's not out of the possibility of being a P wave. So my question or my pearl to you is this. Anytime you look at the EKG tracing and you don't know if what you're looking at is a P wave or not, the next question you should ask yourself is, where are the T waves? Remember that ventricular repolarization is what the T wave represents, and atrial depolarization is what the P wave represents. So, if you think about the way the heart is, and you think about the mass of each chamber, which chamber is significantly larger, an atrium or a ventricle? Hopefully you said ventricle. Well, if ventricles are the larger of the two chambers, would you expect the ventricles to have a larger deflection, meaning greater amplitude deflection, or would you expect the atria to have greater deflection on the EKG? Again, I hope you said the ventricle repolarization process should always be a larger process or a bigger deflection on the EKG than the minute little atria that are depolarizing. So, when your question is this a P or a T wave? The answer is it's always a T wave, because if you only have space for one or you only see one thing, it's got to be a T wave. Now, I may adjust that rule a little bit later when we look at other things on the 12 lead. For now, though, that's what I want you to learn. I want you to learn that when you look at two QRS complexes and in between them there's one hump and it could be a P or it could be a T wave, it's always a T wave. So, do we see any P waves then anywhere along this tracing? And the answer is nope, not a single one. If there's no P wave, there's no PR duration. And what you will notice here, look at this one in particular, it's got this little fibrillatory baseline, fibrillatory baseline, fibrillatory baseline. So instead of a P wave here, we're going to put F waves, little F wave, that's fibrillatory. Let's measure a QRS complex. All right. We already know what this is, but we're going to measure the QRS complex. This one's probably like 1.5 boxes. Let's call it 60 milliseconds. All right, and you'll see the constellation of findings here is a rate greater than 100 per minute, and everything else the same as what we saw on AFib. This is known as atrial fibrillation with rapid ventricular response. So atrial fibrillation with rapid ventricular response is characterized on the EKG by a rate that exceeds 100, irregularly irregular pattern, small fibrillatory waves in between the QRS complexes, no discernible or measurable PR duration, and a QRS duration that is usually normal, all right, so usually less than 120 milliseconds. So this is atrial fibrillation with rapid ventricular response. All right, let's take a look at our next atrial rhythm here. So let's take a look at our rate. All right, let's just use the sequence method here. We'll do about, let's say, 300, 150. So let's put the rate at 150. Now we're going to look at the regularity, and we're going to see that those QRS complexes are about as regular as they can get, so we're going to call that regular. Now we're going to look for P waves, and we're going to go to the area where we expect to find a P wave, and there's going to be nothing there. So there are no P waves here. Now, what do you notice about this EKG, though? What you notice about this EKG is there's this weird-looking thing that's taking place in between each QRS complex, and it happens every single time. So it's not like you hit a little bump in the road. It's not like somebody tapped on an electrode. It's not movement, because it's happening deliberately at the exact same time. Whenever this happens to you, whenever you see something that looks to be deliberate in between QRS complexes, what I would encourage you to do is get another piece of paper and put that piece of paper right along the line of isoelectric, and then cover this part up with the piece of paper so that all you see is this, everything that's below here. And what your eyes should do then is be able to recognize that there's a pattern that's taking place. And this pattern is what I'm trying to reproduce here. And you'll see this pattern that takes place when you put that paper over it. So now what you see is something called flutter waves. All right, so big F waves are called flutter waves. This is what atrial flutter looks like. So these big flutter waves are pretty cool because they're happening also at a specific rate. So let's take a look right around here at the flutter waves. All right, how about we start right about here? You'll see that this flutter wave and this flutter wave, you'll see that the distance between these guys is 5 millimeters. So our ventricular rate here is 150, but our flutter rate or our atrial rate is double that at 300. So there are 2 atrial depolarizations for every 1 ventricular depolarization. The way we do this is just say it's 2 to 1. All right, if there's no P wave, we can't determine PR duration. And let's take a look at a quick QRS complex here. Why don't we start on this big dark pink grid line all the way out to here. It's like 2 and change boxes. Let's call it 100 milliseconds. All right, so a couple things here. Atrial flutter is characterized by a rate, a ventricular rate, and an atrial rate that are some ratio to one another. Atrial flutter is extremely regular almost always. 99.9% of the time it'll be regular. Otherwise, it will be our third irregularly irregular rhythm. I don't want you to worry about the irregular stuff right now. There will be no P wave in atrial flutter. There will instead be flutter waves. No PR duration, and the QRS complex is usually normal. Usually normal. So let's take a look at what happens here with atrial flutter. So we're going to talk about all of the different rates here in just a little minute. I'm going to put them all up on a separate page here in just a second, but why don't we'll do that in just a second. So just for right now, what I want you to appreciate is that the ventricular rate and the atrial rate are to some ratio, established ratio to one another. The most common ratio is 2 to 1 for atrial flutter, where there are 2 flutter waves for every 1 ventricular depolarization or QRS complex. All right, so this is atrial flutter. All right, let's take a look at our next guy here, and let's do the same thing. We're gonna approach it the exact same way that we've done every other piece here. So let's take a look at the underlying rate. Well, this one's really fast, so I'm not going to use the 6-second method, and I'm not going to use the sequence method because it's simply too fast. Instead, what I'm going to do is I'm going to count the number of small boxes between 2 QRS complexes to give me the 1500 method. And I think if you agree here, we're looking at like 5, 7 little boxes. So if we did 1500 divided by 7, we're somewhere right around like a 225-ish range, or somewhere right around there. So you're going to take a look at this, and when you have really fast rates, what you're going to end up doing is using the 1500 method, and the 1500 method ends up giving us, it's actually like a number like 215 maybe instead of 225. Let's change that just in case you guys have a calculator. I'm pretty sure it's 215. All right, so the rate here is 215. Regularity, well, let's look. Whoa, it's perfectly regular. If you measure the distance between any of these 2 QRS complexes, it's perfectly regular. Now, we've always taught to go look for the P wave before the QRS complex, and is that a P wave, is that a P wave, is that a P wave? And then in the previous slide we said, well, if we don't know if that's a P or a T, what must it be? It must be a T wave. So in fact, there's no T wave here. I'm sorry, there's no P wave here. It's a T wave that's there. So there are no P waves that are visible, no P waves before the QRS complex. Now, what I want you to do for a second is I want you to take a look at this EKG, and I want you to look at this little thing that happens after each and every single QRS complex. There's this little hiccup that's there. And just for the sake of discussion for right now, we're going to talk about this a lot in class, but for right now, we're going to call this something called a retrograde P wave. Retrograde because it comes after the fact. So this P wave comes after the QRS complex. It's called a retrograde P wave. Now, when you have a retrograde P wave, you still cannot determine the PR interval. What we can look at is the QRS, and you'll note that the QRS is probably about 40 milliseconds. It's very short because this rate is so fast. So, the constellation of findings here, a rate greater than 150 beats per minute, irregular rhythm, no P waves before, sometimes retrograde P waves after the fact, no PR duration, and a normal duration QRS complex. These are the characteristic findings of supraventricular tachycardia. Now, let's explore this just for a second. So, right atrium, left atrium, here are your ventricles. SA node, AV node. All right. So normally we get a trigger from here, and there's this wave of depolarization that takes place, and there's this wave goes out through Bachmann's bundle and it depolarizes the left atrium. And in the meantime, while all this mess is happening, the AV node is hanging on to the signal that it received, and then eventually, after a little bit of a time break, it allows that to trigger down, and then we get this wave that takes place, and it depolarizes the ventricles upwards. All right, normal heart. All right, so let's take a look at what happens in SVT. In SVT, things are a little bit different. So I'm going to just draw a big picture of the AV node, and I realize that the AV node is not a box, but it's about the best I can do with my drawing here. So this is a picture of the AV node, and up here is atrial tissue. Down here is ventricle. And this is the AV node, and inside the AV node there are two distinct pathways. One pathway kind of goes like this, and another pathway, another pathway goes like this. So there are these two pathways that are in here, and one of these pathways is said to be the fast pathway, the other pathway is said to be the slow pathway, and these pathways are inside the AV node, and depending on how fast the atrial signals are reaching the AV node determines which pathway the signal travels down. So if it's a really, really, really fast or reasonably fast pathway, let's say the atria are firing, let's say, 140 times per minute, well, it's going to go down the fast pathway so that the delay is less inside the AV node than when the underlying rate is 50, for example. Because when the underlying heart rate is 50 beats per minute, we want to give the ventricles more time to fill. So if we have a slow rate coming into the AV node, it goes down the slow pathway, and then meaning that it hangs on to that signal longer. It takes longer for that signal to travel through here, which means it hangs on to it longer, allowing the ventricles more time to fill. Conversely, when we have a really fast rhythm from above, or a fast signaling mechanism from above, then we got to go down the fast pathway to allow the ventricles to fill, but a little bit less, with a little less time than if it went down the slow pathway. Now, the other really important thing you need to know is that these are one-way pathways. So signal can only travel from the top down, all the way down here until it goes down to the bundle of His and eventually gets to the ventricles. Now, in SVT, there's a problem inside the AV node. In SVT, the problem lies within the AV node. And in fact, what happens in SVT is that one of these pathways breaks. And instead of having a one-way valve associated with it, this pathway, for example, the slow pathway, might allow impulses to travel back up this pathway. So a signal comes in from above, it enters here, it goes down the fast pathway, and then for some reason, poof, it goes back up. So it continues to do this in a circular fashion, right? And it continues to go around and around and around and around and around and around and around. And every time the signal gets here, you get a QRS complex on the EKG. But as that signal continues to go back up, it also travels back up into atrial tissue. Well, if it travels back up into atrial tissue, you get atrial depolarization again. You get this little thing that looks like this after the QRS complex. So in the sequence of time, this comes down, it goes down the fast pathway, it goes to the ventricles and causes a QRS, but then it continues back up the slow pathway, back up into the atrial tissue, and you get an inverted P wave after the fact. This is called a retrograde P wave. Retrograde P waves are highly characteristic of a specific type of SVT called AV nodal reentry tachycardia. So SVTs come, there are like 6 different types of SVTs. One of type of SVT is called AV nodal reentry tachycardia. It is characterized by a heart rate greater than 150 beats per minute and the presence of retrograde P waves. The presence of retrograde P waves is highly characteristic of AV nodal reentry tachycardia. And it just so happens that out of all the SVTs, about 70% of them are AV nodal reentry tachycardia. So you're going to find AVNRT as the type of SVT when you find retrograde P waves. We'll talk more about this in class. I also want to draw your attention to something else that exists on this EKG. And again, I'll show you this in class because sometimes it's hard to see. But very characteristic of SVT and AV nodal reentry tachycardia is something called electrical alternans. And electrical alternans is nothing more than a fancy description of alternating amplitudes of QRS complexes. Kind of looks like this. So if you look at the top of this QRS and the top of this one, they're off by about 1 millimeter and change. So this is tall one, short one, tall one, short one, tall one, short one, tall one, short one, and it goes on and on and on. So the presence of electrical alternans and retrograde P waves and a rate greater than 150 in the absence of P's before the QRSs with a regular rhythm is highly diagnostic and characteristic of SVT, specifically of this type of SVT called AV nodal reentry tachycardia. All right, cool. That's a lot to digest. We'll certainly see a lot more of that in class, so don't get too excited about it. This is an easy one. But if you understand that mechanism, this pathophysiological process, now to fix this, all I need to tell you is you give a drug that blocks the AV node. Guess what? Adenosine. So you give adenosine, adenosine's going to come in here and shut this down. Turns it off, literally turns it off. It allows everything to reset. And then when it goes away 10 seconds later, then we don't have AVNRT anymore. We have normal sinus rhythm. All right, so we'll talk more about that in class just to give you this is just as a reference. All right, so I want to make sure everybody understands here that a PAC is not a rhythm. This is not a rhythm. All right. PACs are things that happen within rhythms. They're called premature atrial complexes. Be careful, this is not a contraction. Remember that the EKG in and of itself does not tell us anything about the mechanical ability of the heart. It only looks at electrical things. So to say that we have a premature atrial complex is true because we're going to see a complex or a waveform on the EKG that's consistent with that. To say that's premature atrial contraction, well, actually, we don't know if there was a contraction. We don't know if the heart actually contracted just because we saw electrical activity. All right, so PACs, premature. So PACs are going to be things that happen early in the sequence. They're going to be early. Atrial. The atrial component tells us that there's going to be some sort of P wave activity that we're going to see. And then a complex is that we're going to see something on the EKG. All right, so let's look at the pieces that we know. Here's our QRS complex. Let's go right before our QRS and find our P wave. We'll go right after our QRS and find our T wave. Man, this looks like it's a good story. We got a P, QRS, and T. The P wave looks good. The PR interval is of normal duration. QR interval, normal duration. And our ST and T wave look pretty decent. Our P wave is upright. It's rounded. It precedes the QRS complex. Man, everything is hunky-dory. Now, let's draw our attention to this guy. So what is this ginormous thing that's shown up before this P wave? Well, let's take a look here. This ginormous thing that showed up before the QRS complex. So remember we said a couple slides ago, when you look before the QRS complex, if your question is, well, is that a P or a T? This always has to be a T wave because P waves can easily be masked. T waves cannot. So a P wave can never mask a T wave. In other words, ventricular repolarization is always a larger event than atrial depolarization, electrically speaking. Therefore, if we don't know what this is, we're going to have to call this a T wave for now. But there's more to this picture. Let me clear some of this mess here. There's more to this picture because if you look at the components that we just found just a few minutes ago, you saw that this was a P wave and this was a P wave, and these QRS complexes were of a certain distance from one another. Yet, when we go to this QRS complex, it's a different distance than it is from this one. All right, so there are a couple things that we can do here. One, let's take a look at the amplitude of this P wave, and I think we're going to estimate that to be about 1.5 millimeters. Next, we're going to look at this T wave, and I'm just going to draw this base here for you right here. And I'm going to put this next base right here. That's the top. And now we're going to measure how tall this T wave is, and we're going to find that it's about 3 millimeters tall. Now, we're going to come to this guy here, and we're going to measure how tall this overall guy is here. So we're going to do 1, 2, 3, 4, and about half. This guy happens to be 4.5 millimeters tall. Uh-oh. Now, earlier we said you can't have two events take place at the same time and see them both independently. If two events take place at the same time, they're going to be added on the EKG. So let's say we had a P wave that was 1.5 millimeters and a T wave that was 3 millimeters tall. The total sum of this complex, if they should occur at the same time, would be 4.5 millimeters. Wow. So that's pretty powerful because now we can come back here and say, well, we do have this thing that's 4.5 millimeters. In addition to that, guess what this little guy is here? That's the P wave that's taking place at the same time as the T wave. So the P and the T have occurred simultaneously here, which means that the P wave came early. Now, we have a normal duration PR interval that follows that, and then a normal QRS that follows that. So when we have an early P wave that shows up, followed by a normal QRS with a normal PR interval duration, we call that a premature atrial complex. Now, still don't believe me? This is the other way that we can visualize that. So your heart and my heart, very, very, very smart. And they say, if you have a beat that occurs early in the sequence, we should then give a little pause after that early beat to allow for the normal rhythm to restart itself. So take a look here. If you look at the distance between these two QRS complexes, you're going to note that it's approximately 20 millimeters. It's a little less than that. It's about 19. So what I want you to do is I want you to start at this QRS complex, and I want you to go out 19. So let's go 2, that's 7, that's 17. This is about 19 right here. All right. So actually, this is going to be off a little bit, and that's okay. So here, if we go again, we're going to be about 10, 11, 12, 13, 14, 15, 16, 17. So 19 is probably right around here for this guy. I may have miscounted this too. Hang on, let me double check here. It's close to 19. So in any case, what I want to show you here is that the next beat should have fallen somewhere in this range right here, and it didn't. It came early. So what the heart did, instead of taking this as the measurement for the start point to go out 19 and start again, it had a pause. So instead of following normal suit where it should have to land right there and then go again, instead what it did is after this premature beat came, there was a pause that occurred in this area. This is called a compensatory pause. So compensatory pauses are things that you'll see following premature beats that occur in order for the heart to reestablish its normal cadence on time where it's supposed to be. So, in summary, premature atrial complexes are not rhythms. They are complexes that occur inside of a rhythm. PACs must have a discernible P wave that comes early, followed by a normal duration PR interval and a normal duration QRS complex. PACs must also have concordance between the QRS complexes and the T waves, meaning that if the QRS complexes are upright, the T wave that follows the premature beat is also upright. All right, so we'll certainly do a lot more of this in class. This serves as the foundation or a reference resource for you to come back to and look at. But for the most part, this is stuff that you're gonna get while we're practicing in class with the green books. All right, so stay tuned. We'll do the junctional rhythms and keep on plugging away with these guys as we move forward in class.